I go to ocular muscle imbalance and headache and eye strain. Asthenopia due to improper refraction, we have seen, is the most common problem producing asthenopia and eye strain. Vergence problems in children, and of course, the other group of people who have vergence problems is in the presbyopic age group. And accommodative insufficiency and convergence problems are very closely related, and as seen are either by refractive correction or by prisms we can correct. Muscle imbalance due to vertical and horizontal heterophoria or tropia can also produce asthenopia, which is often overlooked and not addressed well. These are cosmetically insignificant, and often we can try prisms but not very satisfactorily corrected. So this is what I'm going to talk about. Symptomatic strabismus. The normal vertical fusion amplitudes are very low, about 3 to 5 prisms, and so also the negative fusion or divergence amplitude, as you have seen, is about 6 to 10, less than 10 prisms. So even a very small vertical or ESO deviation acquired later in life produce intractable functional issues of diplopia and asthenopia. Sometimes after our surgery for strabismus, a large angle strabismus correction is done, muscle surgery is done, and we leave behind a very small angle strabismus. He may try to binocularly see some near work, and this can produce asthenopia. Occasionally, a small V or A pattern Exotropia can also produce a reading difficulty, mainly by inducing an abnormal head posture, and he has to read with the chin up or down as V or A pattern is produced. So prisms are often unsatisfactory. So let us go through some of the cases. This is a 17-year-old girl. Is there a pointer? This is a 17-year-old girl preparing for entrance examination who presented with complaints of diplopia and blurring when reading and eye strain. She was not aware of any squinting. I don't know if you can appreciate, there is a right hypertropia in primary position, right hypertropia increasing in levoversion, and more in right head tilt. That is, Belchowski's was positive, and there is an underacting superior oblique, maximum hypertropia in the action of superior oblique by cover test. And this was diagnosed as a compensating right superior oblique palsy. So surgical correction was done after doing a superior oblique traction test, and this is how we do a superior oblique traction test. It's not working, I think. Cannot play. It's not. So this is how we do a superior oblique traction test to see whether the superior oblique is lax, and then we opted to do a superior oblique tendon tuck. By strengthening the superior oblique, we could achieve alignment, reducing the hypertropia. So usually after superior oblique palsy, we undertake inferior oblique recession because the overacting muscle is inferior oblique. But in this particular case, we did not have an inferior oblique overaction, so we tackled the superior oblique. How? How do we go to the PowerPoint? Next. Next. Slide. Slide. We have, okay, that hello. That hello. We have to go back through the whole thing. Okay, it's fine. So even very small vertical foria or tropia can produce symptoms of asthenopia, diplopia, loss of place while reading, and fatigue. A decompensated congenital superior oblique palsy is often the cause for new symptoms of asthenopia in an adolescent, and congenital superior oblique palsy is often missed if the head tilt and the facial asymmetry are overlooked. Again, this child seems to have an aligned eye in the primary position. But once you correct the head posture, you can see the left eye goes up. This is because congenital superior oblique palsy, they have a very high fusional reserve for vertical phoria. So they can correct the vertical tropia by tilting their head. So it is well aligned in primary position, but his facial asymmetry and flattening, if you can observe that there is a flattening of the right side of the face, which shows that there was a long-standing head tilt. So this, when he has good fusional reserves now, but when it decompensates, it can produce eye strain. So this is another case of traumatic. After fall, he developed diplopia, and the wife brought him. He was a carpenter with a 5 years history that he cannot work at the carpentry because he sees double when he is drawing line on the planks. So there was blurring and difficulty in focusing. There is very, very subtle vertical tropia, so he was discharged from most of the places as saying there is no squint. Though there is no vertical deviation, there is a torsional diplopia which is detected subjectively by double Maddox rod test, and we can even see the fundus was extorted, and surgical intervention completely relieved him of the complaints. He has a superior oblique palsy. Again, I think this is a Haradito procedure done, and his torsion completely was relieved after the Haradito procedure, which strengthens the anterior torsional fibers of superior oblique. The posterior fibers, which are meant for vertical function, that is depression, we are not touching. No. Okay, I think we'll move on to the next slide. He was completely relieved after doing Haradito procedure. So this is another case, a 30-year-old teacher who presented with complaints of asthenopia and diplopia while reading for the past few years. He had to lift up his chin and could not read books or write on the blackboard comfortably. On examination, he had a chin-up posture, as you can see here, and he had unaided visual acuity 6.6. Prism bar cover test showed an 18 prism base out in elevation, 8 prisms in straight ahead primary position, and there was no deviation for depression at all. So, and his fusional divergence was 6 prisms, which he was using to try to control this deviation. So, on the table, we look for the deviation, and then we did a mini tenotomy of the medial rectus. This is a topic. This is done under topical anesthesia and can be done as a daycare procedure. So, and it is tailored according to how much diplopia is there after surgery. You do again prism bar cover test on the table after doing this is through the conjunctiva after marking over the conjunctiva. This is medial rectus is disinserted in the middle 1/3 at the insertion. So at the end of the procedure, you need not even suture the conjunctiva. And this can be done bilaterally. In this particular case, it was done bilaterally. You may put a suture. And at the end of the procedure, on the table, you see whether prism bar cover test produces any deviation is there in the primary position. In elevation, even if there is a small amount of esotropia, it is okay. So this teacher was completely relieved of his symptoms. And if you want, you can do further disinsertion of the inferior oblique. Up to 60 to 70% can be done. This boy had a large exotropia and was corrected horizontally. He looked okay, but then vertical, there was a very small vertical hypertropia, left hypertropia, and diplopia. We waited till he for 8 weeks, but he could not tolerate the diplopia. So we did a graded vertical rectus tenotomy under topical anesthesia. Again, the patient is asked to look away from superior rectus, where we are going to operate on, and temporal to the insertion. We hook the muscle. Even hooking doesn't produce much of a pain when topical anesthesia is used. This is just Paracaine with no other sedation. And after clamping the muscle temporally for a few minutes, you do a graded tenotomy. This can be done up to 60% of the temporal insertion of superior rectus. But again, you have to do in a graded manner, asking the patient to sit up and do the prism bar cover test again and again until he is okay. If it is not completely relieved by right superior rectus, meaning tenotomy, you can do left inferior rectus. So after this procedure, we see again whether there is any hypertropia, and so this is how you tailor it. So this is another situation, intermittent exotropia. If he has good fusional reserves, I don't know why these were all. You can see the fusional reflex in this boy. So long as he has good fusional reflexes, there will be no problems. But as he grows older, this fusional reserves reduce, and then they manifest again and again. It goes into intermittent tropia. So that is when we have to do surgical correction. So a decompensating intermittent exotropia is another case where you have to tackle surgically, and when fusional convergence amplitude fails. So this is an A pattern, superior oblique overaction was there, so we had to do 4 muscle surgery. So diplopia and eye strain is troublesome even in small deviations in vertical and iso deviations. And decompensated superior oblique palsy is a common cause which is overlooked. Traumatic superior oblique palsy also can produce troublesome diplopia and eye strain. And decompensation of intermittent exotropia when they lose convergence in efficiency, and small symptomatic deviations after surgery. Mini tenotomy or a graded tenotomy can be done under topical anesthesia, which can be repeated also. That is another advantage. You don't have to admit the patient, no need for anesthesia in adults. Okay, thank you.